We'll be breaking down all major concepts covered on the exam. I'm Harvey, one of your hosts for today's review session.
And I'm Donna. We are expert MCCQE reviewers, and, well, our mission here is to help you, the Canadian medical student, feel fully comfortable with the exam review process.
Exactly. We want you walking into test day with, absolute confidence, ready to tackle even the most nuanced clinical vignettes.
Right. And to do that, today's deep dive teaches directly from reliable StatPearls articles. We're focusing on section SO7, infectious diseases.
Specifically, we're zooming in on nosocomial or hospital-acquired infections. But before we jump into the clinical material, we do need a mandatory disclaimer.
Yes, very important. This session is for medical education only, not medical advice. All clinical decisions should involve a qualified healthcare provider.
Perfect. So imagine a patient survives this, grueling 10-hour triple bypass surgery. The surgical team is flawless, the heart is pumping beautifully.
Sounds like a success story.
Right. But a week later, that same patient is in the ICU, crashing, hypotensive, and fighting for their life.
And the culprit isn't a failed graft.
Exactly. It's a microscopic organism that hitched a ride on a piece of plastic tubing. I mean, that is the reality of hospital-acquired infections, or HAIs.
It's terrifying, honestly. They affect 3.2% of all hospitalized patients in the U.S.
And up to 6.5% in Europe. It's just a massive source of morbidity, mortality, and, frankly, enormous financial strain.
Yeah, they represent the single most common adverse event affecting patient safety globally. I mean, you spend all this time learning how to cure complex diseases, but...
But if you can't protect the patient from the hospital environment itself, it all falls apart.
Exactly. So for the MCCQE, you have to understand the fundamental ground rules before you even look at the specific pathogens.
Right, because you really cannot afford to get tricked on a timeline question. The timeline dictates everything about how we categorize and treat the patient.
So let's define it. The core definition is that the infection must not have been present or, incubating at the time of admission.
And for the boards, that typically means an HAI occurs greater than 48 hours after admission.
Yes, the 48-hour mark is your crucial anchor.
But the trick, and they love testing this, is that it can also appear after the patient is discharged, right? Or even affect the occupational staff working in the hospital.
That's a great point. But going back to that 48-hour anchor, the biological rationale is that 48 hours generally covers the incubation period of most community-acquired pathogens.
Makes sense. So if a patient spikes a fever and has lung infiltrate, say, 12 hours after admission.
They brought that pathogen in through the front door. It's community-acquired.
But if it happens 72 hours later, the hospital gave it to them.
Right. And your differential diagnosis, along with your empiric antibiotic choices, completely diverges based on that timestamp.
So let's talk about the landscape of these infections, because there was a major epidemiological shift in the data around 2015.
Oh, yeah. Historically, surgical site infections, or SSIs, they totally dominated the charts.
Right, but the data shifted. Now, pneumonia is actually the most common HAI in acute hospital settings.
Followed closely by gastrointestinal infections, like Clostridioides difficile.
Which we'll definitely get into. But breaking down that pneumonia stat, it's interesting because the single most common type in acute care is actually non-ventilator-associated hospital-acquired pneumonia.
NVHAP.
Right.
It actually outpaces ventilator-associated cases, which surprises a lot of people.
Yeah, students often assume the ventilator is always the culprit because it's this huge invasive machine.
Exactly. But you have to consider the sheer volume of elderly, bed-bound, non-intubated patients who are at risk of microaspiration. That makes NVHAP the statistical leader.
That makes perfect sense when you consider the aging population. So knowing the pathogens is half the battle. Bacteria absolutely dominate this space.
They do, stemming from either an exogenous source in the environment or the patient's own endogenous flora that, relocates to a sterile site.
And the gram-positive heavy hitters are just relentless. We're talking coagulase-negative Staphylococci, MRSA, and VRE.
Vancomycin-resistant Enterococcus.
Yeah.
And then you have the gram-negatives, which are arguably more terrifying in an ICU setting.
Oh, for sure. The Enterobacteriaceae family, Pseudomonas aeruginosa, and crucially, Acinetobacter baumannii.
Yes. If you see Acinetobacter on a question stem, you need to immediately associate it with the ICU and very high mortality.
Because it's so resilient.
Exactly. It has this incredible ability to survive on dry environmental surfaces for weeks. Plus, it possesses inherent multi-drug resistant properties.
It just renders standard antibiotics practically useless. And we also have to watch out for fungi. Candida species make up the fourth most common pathogen overall.
And then there's a classic board trap with fungi, Aspergillus fumigatus.
Oh, yeah. The dead giveaway on a clinical vignette is the mention of hospital construction or renovation near the patient's ward.
Right, the underlying mechanism there is aerosolization.
Like tearing down drywall or moving ceiling tiles?
Exactly. It kicks up Aspergillus spores that have been lying dormant. A healthy immune system clears them easily.
But profoundly neutropenic or immunocompromised patients inhale them, and you get invasive pulmonary aspergillosis.
Which is devastating.
You know, I often think of the hospital environment as a synthetic biome. It's this unique ecosystem filled with highly resilient, multi-drug-resistant predators.
Constantly hunting the most vulnerable prey, our immunocompromised patients.
Right. But if these bugs are everywhere, on the bed rails, the curtains, our stethoscopes, why do they preferentially attack specific sites, like the bloodstream or the urinary tract?
Well, because the human body's natural defenses are exceptionally robust. Intact skin and mucous membranes form an incredible physical fortress.
So they need a breach.
Exactly. The vast majority of these multi-drug-resistant pathogens cannot penetrate intact skin. The easiest way for them to take hold is when we literally install a direct highway into the body.
Right, bypassing the physical fortress with invasive devices, central venous lines, and urinary catheters.
That's the mechanism. We breach the barrier for therapeutic reasons. But it goes deeper than just providing a physical opening.
It's about how the bacteria adapt to the devices, right?
Yes. These pathogens have evolved virulence factors specifically suited for artificial surfaces. They produce biofilms.
And a biofilm is what, like an extracellular polymeric substance?
Yeah, a sticky yet protective slime that the bacteria secrete. It allows them to adhere strongly to foreign plastic and metal.
And it shields them.
Completely. It shields them from both white blood cells and systemic antibiotics.
Wow. Okay, let's apply that biology directly to the device-associated traps on the exam, starting with clabicide.
Central line-associated bloodstream infection.
Right. The skin flora, typically coagulus-negative staph, or S. aureus, tracks down the exterior of the central line, utilizes that biofilm to set up camp, and just continuously seeds the bloodstream.
And when diagnosing a clabicide, the exam will absolutely test your understanding of proper culturing technique.
To rule out mere skin contamination, right?
Exactly. You must draw blood cultures from two distinct sites, one sample from the central venous catheter and the other from a peripheral vein.
And you do this before initiating any empiric antibiotics.
Always.
The logic there is fascinating, actually. It's about differential time to positivity. If the blood drawn from the central line turns positive hours before the peripheral blood turns positive, it proves the central line is the primary source.
Right. It's the factory churning out the bacteria.
But here's where I want to push back a little on the management side.
Okay, go for it.
So this standard exam algorithm says we need to remove the central line if the cultures come back positive for Candida, S. aureus, or Pseudomonas.
That's right.
But in real-life clinical practice, what if the patient has terrible venous access? Say they're on 3 different vasopressors, and losing that central line might literally cause them to code.
Yeah, that is the eternal struggle of the ICU attending. In practice, you might temporize or try to salvage a line under extreme multidisciplinary oversight.
But on the exam,
You cannot bring that hesitation to the MCCQE. The board wants to ensure you understand the sheer lethality of those specific organisms.
because they don't just cause transient bacteremia.
Exactly. S. aureus, Pseudomonas, and Candida are highly virulent, produce dense biofilms, and have a massive propensity for metastatic infection.
So if you leave a line infected with S. aureus in place,
The patient is highly likely to develop endocarditis or osteomyelitis. The algorithm dictates removal because the risk of leaving it far outweighs the logistical difficulty of getting new access.
got it. So when sitting for the exam, shut out the logistical hypotheticals. If you see those 3 bugs, pull the line.
Pull it every time.
Okay, let's look at the other Meiji plastic tube. The urinary catheter leading to CAUTI or catheter-associated urinary tract infection.
The single most critical risk factor here isn't patient age or immune status.
It's strictly the duration of catheterization, isn't it?
Precisely. Every single day a Foley catheter remains in place, the daily risk of bacteriuria increases by about 3 to 7%.
Which leads directly to the highest yield diagnostic trap for CAUTI.
Yes, differentiating between colonization and true infection.
Students get tripped up on the numbers here all the time. If a catheterized patient's urine culture shows greater than 100,000 colony-forming units, or CFUs, per milliliter, but they feel completely fine, No fever, no pain.
That is asymptomatic bacteriuria.
And we absolutely do not treat it.
Treating asymptomatic bacteriuria is a major clinical error. It applies evolutionary pressure to the biome, wiping out susceptible bugs and selecting for highly resistant strains.
So what's the actual criteria for CIUTI on the exam?
To definitively diagnose it, you need a culture showing greater than 1,000 CFUs per milliliter of a recognized uropathogen combined with clinical symptoms,
Symptoms like fever, suprapubic tenderness.
or costovertebral angle pain, or unexplained acute hematuria.
And there's a very specific procedural detail regarding how that culture is obtained. You can't just draw urine out of the old collection bag hanging on the bed frame.
No, if you culture the old bag, you are merely culturing the biofilm on the plastic.
So the sample has to be.
A midstream urine sample taken after the old catheter has been removed.
Got it. And as for prevention, if a catheter has been in for more than 2 weeks, the biofilm is so extensive that antimicrobial therapy will likely fail if the plastic remains.
Right. And do not fall for distractor options on the test, like using antiseptic-coated collection bags or routine antimicrobial irrigation of the bladder.
Those don't work.
They do not prevent CAUTI, and they actually promote resistance. Just remove the catheter as soon as clinically possible.
Okay, so we've covered the plastic tubes breaching the defenses. Let's shift to the physical traumas and compromised mechanics our patients face: surgical incisions and respiratory intubation.
Starting with surgical site infections, or SSIs, the diagnostic timeline is non-negotiable here.
By definition, an SSI must manifest within 30 days of the operative procedure, right?
Yes, but the boards love to test the exception.
Which is?
If a prosthetic device was implanted, like a total knee arthroplasty or surgical mesh, then the surveillance window extends to 90 days.
Ah, because those foreign bodies can harbor indolent, slow-growing infections. Now, the prevention of SSIs comes with a classic trap regarding patient prep. Say the question stem describes a patient getting ready for abdominal surgery and asks for the best method of hair removal.
They'll offer a razor, cleaving, or depilatory creams.
And the razor is always the wrong answer.
Always. Shaving causes microscopic trauma to the epidermis.
It's literally like tilling the soil right before you drop bad seeds in.
That's a perfect analogy.
You're taking intact skin and creating thousands of microscopic lacerations. So the normal skin flora, like Staphylococcus epidermidis, suddenly has thousands of tiny pockets to multiply inside.
Completely bypassing the surface barrier before the surgeon even makes the first incision.
So if hair must be removed, use clippers.
Yes, clippers only. And beyond skin prep, you're tested on intraoperative physiological parameters. Optimizing tissue oxygenation and immune function during surgery is critical.
So the anesthesiologist has to maintain euthermia.
Right, keeping the core temperature above 35.5 degrees Celsius.
Because hypothermia causes peripheral vasoconstriction, right?
Yes, which decreases oxygen delivery to the wound and impairs the oxidative killing capacity of neutrophils.
Makes sense. Another critical parameter is strict glycemic control. And this trips people up. Why do we care so much about the blood sugar of a non-diabetic patient during surgery?
Because hyperglycemia physically paralyzes immune cells,
Right. The elevated glucose leads to glycation of proteins.
which severely impairs neutrophil chemotaxis and phagocytosis. You want to keep intraoperative and postoperative blood glucose strictly under 180 milligrams per deciliter.
Under 180. Got it. Okay, moving from the surgical site to the respiratory tract, we need to clearly delineate HAP and VAP.
Hospital-acquired pneumonia develops greater than 48 hours post-admission. Ventilator-associated pneumonia develops greater than 48 hours strictly after endotracheal intubation.
Because the endotracheal tube essentially holds the vocal cords open.
Right, bypassing the cough reflex and providing a direct conduit for oral secretions to microaspirate into the lungs.
And diagnosing these requires radiographic evidence. The chest X-ray has to show new or progressive infiltrates.
But an X-ray alone is not enough.
Right, because the differential for a new infiltrate in a critically ill patient is really broad.
Exactly. You have acute respiratory distress syndrome, or ARDS, which involves severe inflammation that causes fluid to leak into the alveoli.
And on an X-ray, that non-cardiogenic pulmonary edema looks nearly identical to a bacterial pneumonia.
It does. So to confirm HAP or VAP, you must combine the radiographic evidence with clinical signs.
Like a new onset fever, purulent sputum, or a sudden drop in oxygenation.
And microbiologic sampling from the lower respiratory tract.
Now, once you have clinical suspicion and have drawn your cultures via endotracheal aspiration, you do not wait around for the lab, right?
Never. The mortality rate is too high. You initiate empiric treatment immediately.
Which means bringing out the heavy artillery. The initial regimen usually requires a backbone that covers MRSA and Pseudomonas.
Like combining vancomycin with cefepime or piperacillin tazobactam.
But, and this is but the hallmark of a competent physician and what the exam heavily tests is antimicrobial stewardship.
The moment those final culture results return at 48 or 72 hours, you must de-escalate.
So if the lab shows the pneumonia is caused by a highly sensitive streptococcus,
You stop the broad-spectrum carbapenems and vancomycin. You narrow your coverage. Maintaining broad-spectrum coverage longer than necessary is exactly how we generate the multi-drug-resistant superbugs that haunt the ICU.
all right, so we've covered the bloodstream, the bladder, surgical wounds, and the lungs. Now we face the GI tract,
The single most common organism encountered in all hospital-acquired infections.
responsible for roughly 15% of all infections with a reported pathogen in U.S. hospitals. It is Clostridioides difficile.
Healthcare facility onset C. difficile infection, or HOCDI. It manifests as severe antibiotic-associated diarrhea and potentially fatal pseudomembranous colitis.
The pathophysiology relies on two major toxins, right?
Yes, toxin A, an enterotoxin that causes massive fluid secretion, and toxin B, a potent cytotoxin.
Toxin B literally destroys the cytoskeleton of the intestinal epithelial cells.
It's brutal. To understand the exam questions on C. diff, you have to grasp the modifiable risk factors.
The two major triggers being environmental contamination with C. diff spores and recent broad-spectrum antibiotic use.
Because the antibiotics act like a forest fire in the gut. They wipe out the healthy, competing flora that normally keeps C. diff in check.
And once the competition is gone, C. diff just proliferates rapidly.
Which brings us to the diagnostic algorithm. This is arguably one of the most critical testing traps on the MCCQE.
Yeah, diagnosing C. diff is not as simple as just ordering the most technologically advanced sensitive test available.
You're referring to the nucleic acid amplification test.
Right. Wait, so because NES is so sensitive, using it first can actually trick us into overtreating a patient who is just colonized but not actually infected.
Precisely. It's a massive MCCQE trap. The NAT detects the C. diff toxin gene with incredible sensitivity, but detecting the gene is not the same as detecting active disease.
Because a lot of hospitalized patients are asymptomatically colonized with C. diff.
A massive portion of them. The NATIS will amplify the DNA and flag positive even if the bacteria are essentially dormant and not causing any harm.
So if you use NAT as your initial screening test, you just trigger a wave of false positive diagnoses,
leading you to pump unnecessary antibiotics into patients who are merely colonized.
I like to think of the NAT as like finding a burglar's footprint in the backyard. It proves they were there, and they have the potential to break in, but it doesn't mean a crime is actively occurring.
That is an excellent analogy. We need to see the active crime. We need to see the active production of toxins causing tissue damage.
Like the burglar throwing a brick through the window.
Exactly. Therefore, the exam requires a stepwise algorithm. You begin with an enzyme immunoassay, or EIA.
Okay, and the EIA looks for the actual presence of toxins A and B in the stool.
Yes, alongside the glutamate dehydrogenase, or GDH antigen.
So we run the EIA first to look for active toxin production. When does the NAT actually come into play?
You only utilize the highly sensitive NAT as a tiebreaker.
Ah.
So if the initial EIA results are indeterminate or discordant, say the GDH antigen is positive, meaning the organism is present, but the toxin screen is negative, then you step up to the NET to confirm if the toxigenic gene is actually there.
Got it. And there is also a strict physical requirement for the stool sample itself that shows up on exams constantly.
You must only test liquid stool.
Huh.
It has to physically conform to the shape of the specimen container.
So if a nurse sends down a formed stool sample,
The lab should reject it. Testing formed stool will inevitably yield false positives from colonization.
the clinical definition of significant diarrhea requiring testing is what, 3 or more unformed stools within a 24-hour period?
Correct. 3 or more.
Okay, so once we've correctly navigated the algorithm and diagnosed an active C. diff infection, treatment begins immediately. The first step, whenever clinically feasible, is to discontinue the inciting antibiotic.
The one that caused the gut flora imbalance in the first place.
Yes.
Then you initiate specific targeted therapy.
Which is usually oral vancomycin or oral fidaxomicin.
Right. And a classic trap here is selecting intravenous vancomycin on a multiple choice question.
Because IV Vanco is great for systemic MRSA, but it doesn't cross the bowel wall effectively.
Exactly. To treat C. diff colitis, the drug must remain inside the gut lumen, which strictly requires oral administration.
Let's scale back to institutional prevention really quickly because stopping the spread of C. diff is heavily tested.
Right. The World Health Organization dictates 5 moments of hand hygiene.
Before touching a patient, before clean procedures, after body fluid exposure, after touching a patient, and after touching patient surroundings.
And across the hospital, alcohol-based hand sanitizers are universally preferred over soap and water.
Because they're faster, highly effective against most vegetative bacteria, and they improve staff compliance.
Right. However, there is a legendary exception to this rule that is guaranteed to appear on your exam.
The C. diff spore exception.
Yes. Alcohol-based sanitizers chemically destroy cell membranes, but C. diff spores are enveloped in a robust keratin-like coat.
They are practically armored against alcohol.
So if you are exiting the room of a patient with C. diff, or if your hands are visibly soiled with organic material, alcohol gel is entirely insufficient. You must use soap and water.
The soap doesn't necessarily kill the spores, though, right?
No, it doesn't. It's the physical, mechanical friction of rubbing your hands together and rinsing that lifts the spores off your epidermis and washes them down the drain.
If you just rely on alcohol foam, you'll just smear the live spores around your hands and carry them directly to the next patient's bedside.
Exactly. The mechanics of prevention are just as important as the pharmacology.
Absolutely. All right, let's do a rapid recap of the highest yield takeaways we've covered today. First, the timeline rule.
Nosocomial infections generally occur greater than 48 hours post-admission.
And surgical site infections give you a 30-day window, which expands to 90 days for prosthetic implants.
Second, the diagnostic thresholds. For CIUTI, you must see greater than 1,000 CFUs from a midstream sample drawn after the catheter is removed.
Accompanied by clinical symptoms. Never treat asymptomatic bacteriuria.
Third, your CLAB SI line removal triggers. You must pull that central line if cultures return positive for Candida, S. aureus, or Pseudomonas.
And finally, the GI tract algorithms. For C. diff, only test unformed liquid stool. Utilize the stepwise approach.
Start with the EIA for active toxins and only step up to the NAN if the results are indeterminate.
And remember the physical mechanics of hand hygiene. Use soap and water friction to wash those spores down the sink.
You know, as you study these criteria, realize that distinguishing a true infection from mere colonization isn't just about selecting the right multiple-choice bubble.
Yeah, whether you're dealing with an asymptomatic catheterized bladder or a dormant C. diff spore, identifying the difference is a core clinical skill.
It's what separates a dangerous, overprescribing physician from a competent steward of patient safety. You really are on the front lines of preventing the global antimicrobial resistance crisis.
The stakes are incredibly high, biologically and systemically. Every time you correctly withhold unnecessary antibiotics or prevent an infection through proper sterile technique, you are protecting the efficacy of modern medicine.
It's a huge responsibility.
It is. And, I want to leave you with a final thought on the sheer economics of what we've discussed today. According to the StatPearls data, hospitals can see a profit of up to $582,464 by eliminating just one single hospital-acquired infection.
Wow. Over $500,000 for one infection.
Right. Because avoiding that infection eliminates massive administrative costs, frees up ICU beds, and drastically shortens the length of stay.
The financial burden of HAIs is staggering. When you prevent one, you don't just save that patient. You open up resources for the entire healthcare system to function more effectively.
It really makes you evaluate the macro structure of our healthcare economy. So here is a provocative question for you to mull over during your next study break. If infection prevention is this massively profitable for hospitals, and we know it saves thousands of lives, how might the future of medicine shift?
That's a great question.
Could we see a system that pays doctors and healthcare networks entirely based on their prevention metrics and safety outcomes, rather than the sheer volume of procedures they perform?
It would be a profound paradigm shift. As you prepare for the MCCQE in your clinical rotations, keep that big picture in mind. Your attention to these microscopic details shapes the entire healthcare system.
Well said. Happy starting, everyone. See you on the next deep dive.